Good evening, everyone. Welcome to the webinar series from the Rainbow Children Heart Institute. I really thank everyone for attending this webinar. I know it's difficult during COVID time as well as festive season. Uh, we are all in a position that we can't do anything. We are stuck up rather than it's a situation very bad during this pandemic. So probably that made us to think to have more and more webinars. I am attending a lot of webinars every week, and also I am participating as a faculty and a speaker in some of these programs. Can you see the slides? Can anybody can respond whether they can see my slides? How to know this?
Yes, sir, we can see, sir.
Okay, that's fine. I will open the chat box also. Parallelly, I will see some questions which are coming from this. That's fine. So I think quite a good number of people are attending this program. I am seeing that. So with that introduction, I am Dr. Nageshwara Rao, pediatric cardiologist from Children Heart Institute, Rainbow Hospital, Hyderabad. And today we are going to discuss about the diagnosis and management of heart disease in children. So if you look at the postnatal transition, this is the most crucial thing. The three important structures which are going to change from fetal circulation to the neonatal circulation are ductus venosus. The ductus venosus, the umbilical vein enters the left portal vein, and a sphincter like structure called ductus venosus will pump the all oxygenated blood into the inferior vena cava. From there to the right atrium, through foramina ovale it will go to the left atrium. From there oxygenated blood will go predominantly to the head and upper part of the body, whereas the deoxygenated blood, some amount of oxygenated blood will go to the right atrium, to the right ventricle, to the pulmonary artery. From there it will supply to the descending aorta. So there is a watershed dark area called isthmus. So you have a ductus arteriosus. As soon as the baby is born, the first breathing itself will take oxygen to the lungs. The pulmonary vascular resistance will start falling. Lungs is from solid state, it will go into the a spongiform shape state. Then oxygenation will be taken place. So all this oxygenated blood from the pulmonary arteries will go into the pulmonary veins. The blood PO2 levels will be increased. PO2 is a potential vaso ductal smooth muscle constrictor, and PVR also will be fallen. At the same time, the pulmonary vascular resistance will be fallen, and also duct smooth muscles will start constricting. So once the ductus arteriosus constricts, automatically the blood from the left ventricle will go predominantly to the ascending aorta, all into ascending aorta, neck vessels, and also into the descending aorta. So there will be acute rise in systemic vascular resistance. Earlier, the aortic iliac vessels are exposed to the low resistance placenta. Now it is exposed to the high resistance systemic vessels. So there is acute left ventricular to the aortic decoupling will be there. If there is any obstruction to the aortic wall, interruption aortic arch, or coarctation, there will be tremendous amount of pressure to the left ventricle, leading to the ventricular dysfunction. Similarly, because the duct is getting closed, the right ventricle cannot pump into the descending aorta because the duct is closed, PDA is closed. If there is any obstruction to the pulmonary veins, the pulmonary vascular resistance will not fall down. So right ventricle will go into acute ventricular arterial decoupling system. So you will have a scenario of severe right ventricular dysfunction. So postnatally, based on the ductus arteriosus and fall in PVR, and presence or absence of the foramen ovale, lot of congenital heart disease they manifest. So transposition of a great vessel, what will happen if the ductus arteriosus closes, foramina ovale closes, there will be complete parallel of the blood circulation. So oxygenated blood from the pulmonary veins come to the left atrium, left ventricle, and then to the pulmonary artery. Deoxygenated blood from the right ventricle to the aorta. There won't be any mixing, so they present very early in life. Similarly, obstruction to the systemic outflow, total anomalous pulmonary venous return, hypoplastic left heart syndrome, coarctation, interrupted aortic arch, all these structural heart problems can present in the first few days, that is first 72 hours, based on the ductus arteriosus. Pulmonary atresia, they present somewhat little bit later. They don't present immediately. They present a little bit later because the pulmonary the blood PO2 levels in pulmonary atresia because of the admixture is comparatively lesser compared to the transposition and other admixture lesions. That's why the closure of the ductus arteriosus is not as early as like a hypoplastic left heart syndrome, interrupted aortic arch. They present beyond the first week or after few days after time. Cases like where pulmonary vascular resistance falls, like in large ventricular septal defect, atrioventricular septal defect, all kappa, cardiomyopathy, they present a little bit late compared to other heart diseases between 4 to 6 weeks of age, because PVR falls and more shunt will be there. So in summary, the clinical presentation of the congenital heart disease in neonates: number one, hypoplastic left heart syndrome presenting as a shock, obstructive TAPVR, coarctation of aorta, critical aortic stenosis. All these systemic obstructive diseases, they present with a shock within first 3 days. Whereas conditions they produce cyanosis like a transposition of great vessels, pulmonary atresia, they present again within first few days, that is first week itself. Whereas congestive heart failure, AV valve regurgitation, systemic AV fistula, like you have vena of Galen malformation or hepatic AVM, or sometimes total anomalous pulmonary venous return without obstruction, they can present as congestive heart failure. Some conditions we don't recognize them during neonatal period. Examples like Al Kappa, they present beyond neonatal period. Long QTC syndrome, whenever they have a drug which is causing prolonged QTC, then only they present. So these are the some of the cases, some of the clinical examples when they present. We all should understand that. How to recognize this congenital heart disease in neonates? Unfortunately, in neonates, there is no history. You can't take any history. The only presentation may be shock, maybe cyanosis, maybe heart failure, or most of the times asymptomatic. Today itself, I got one baby that is coming after 2 weeks with murmur only. The baby is having a critical PS and very tiny, very subtle clinical findings like a cyanosis. So if you don't auscultate, you probably will obviously miss, and they present with severe cyanosis and other things because of the right to left shunt across the foramen ovale. No obvious clinical findings. TGA, believe me, several times we miss because there are no auscultatory findings. Pulse will be normal. The only finding may be cyanosis. Suppose you have a ductus arteriosus, you have good atrial septal communication, you cannot diagnose because saturations are around 85. When do you diagnose cyanosis? If the cyanosis desaturation is lesser than 85%, or deoxygenated hemoglobin more than 5 grams per deciliter, then only you will diagnose. Otherwise you can't diagnose. And unable to auscultate certain times, like a baby with For an example, you have diaphragmatic hernia, meconium aspiration pneumonia, and lung infection. You won't be able to appreciate the murmurs. You won't be able to appreciate other auscultatory events. That time, definitely we miss the heart diseases. And variable presentation due to unusual natural histories. So the natural histories are quite different in time to time based on the ductus arteriosus, based on the foramina ovale, and also fall in PVR. That's why one pediatrician, neonatologist misses a diagnosis, another pediatrician or neonatologist picks up. So that doesn't mean that the first person who actually missed it, because this is a natural history of heart disease, which we all should know it. And the presentation may be the last, the first presentation may be the last. For an example, baby presenting with severe stridor, that may be due to double aortic arch, and you intubated, and baby will never come out unless you operate it. Several times we miss all these things. So that's why the recognition is very, very important with the subtle clues. That is what we need to emphasize that. So here you can see some of the examples here. Baby will have tachypnea, bradycardia sometimes, blood pressure may be high, low, hypothermia, weak pulse in case of coarctation, inspiratory stridor, asymmetrical chest movement, unlabored breathing, and grunting. So grunting is nothing but a physiological means of PEEP. What we do PEEP? Positive end expiratory pressure. We increase the PEEP in certain situations where alveoli is filled with exudates, like interstitial edema, alveoli completely interstitial lung disease, or ARDS, or pulmonary edema. Whatever it is, you increase the PEEP in the ventilator. So similarly, neonates who has a pulmonary edema, they adopt the respiration towards the PEEP. It is nothing but a grunting. So what will happen at end expiration? They will have this to keep the alveoli patent. So when you see a grunting kind of respiration, probably you should understand that you may be dealing with a systemic obstruction, like it may be TAPVR obstructed, or ventricular dysfunction due to severe aortic stenosis, or hypoplastic left heart syndrome, or coarctation of aorta. So whatever it is causing pulmonary edema and producing alveoli exudates, babies will have a grunting kind of respiration. So important thing is femoral arterial pulsations. Pre-discharge femoral arterial pulsation is mandatory for all neonatal babies. You have to document two important things at the time of discharge. One is pulse oximetry saturation of upper limb and lower limb. Second is femoral and brachial pulsations. It should be physically mandatory to do that. Reason for that, as in several babies not detected during neonatal period, they will have mild coarctation with disparity in pulse. They go home within 24 to 48 hours, they come with severe acidosis, shock, and cardiac arrest, renal failure. Several examples are there. So my request, my suggestion to all of us, we should take a oath that we should record pre-discharge pulse oximetry saturation of the right upper limb and one lower limb, and pulse for all neonates who are getting discharged from the NIC. So if you can't do that, at least we should ask a nurse to see the pulse oximetry waveform. A normal pulse oximetry waveform will have a plethysmography, a steep upslope and downslope like this. You can see beautiful pulse oximeter waveform. In case of coarctation of aorta or interruption, or sometimes low cardiac output due to shock, you will have a delayed descending limb and blunted signal will be there. So this suggests that indirectly that this baby is having a systemic outflow tract obstruction. So this is important to have this kind of information when you are in ICU, or when baby is coming to your NICU or ER with future suggestive of a shock, and you will be able to find out. Let us see some of the illustrative examples here. So this is a neonate here, a 12 hours newborn, LSCS, presented with poor perfusion, low saturation, fetal echo was normal, baby was resuscitated and kept on HFO, heart sounds were normal, could not detect anything, pre-ductal saturation 76, post-ductal saturation 80%, and ABG is this. This is X-ray. So anybody would like to type your answers? Maybe we can discuss this for 10 seconds. I actually request, can we have some kind of interactive session? So what is this X-ray? So this X-ray is, you can see that a cardiac shadow is getting obscured, and bilateral symmetrical reticular pattern is there. You can see the significant reticular pattern on both the sides. The nasogastric tube here suggests of situs solitus. This is symmetrical reticular pattern. You have three important differential diagnoses. One is late presentation of HMD. Late presentation, not immediately. Somehow they improved, or they did not present early, late presentation. Second is severely obstructive total anomalous pulmonary venous return. The pulmonary veins are obstructed. Common pulmonary vein to the vertical vein is obstructive, leading to the intrauterine pulmonary edema. This is actually due to lymphatic edema, lymphangectasia, some people call it as. And sometimes you have late presentation of group B streptococcal infection in a neonate also can have these kind of radiological features. So these are the subtle clues to actually come to some understanding. Baby improved from the shock, but continues to have low saturations and not maintained even on HFO. There was intermittent dip in saturation that may be due to pulmonary arterial hypertension crisis, and also variation in the heart rate, and there is appearance of pansystolic murmur. If you leave these cases like this on ventilation, they will have significant right ventricular dysfunction leading to the development of a tricuspid regurgitation. Echocardiogram showed that there is a right heart dilatation, small AST with right to left shunt, moderate tricuspid regurgitation, and a small PDA with right to left shunt. So when you have a right ventricular systolic pressure 48, some cardiologist, adult cardiologist, I don't want to tell that, they may tell it's a moderate PAH. But if you analyze this echo, right to left shunt across the foramen, across the ductus arteriosus, it is always called as suprasystemic right ventricular pressure, suprasystemic pulmonary artery pressure. Any echocardiogram which is giving you information right to left shunt across the PDA, irrespective of the small size of the PDA, which suggests that it is suprasystemic pulmonary artery pressure. Don't believe your RVSP, because right ventricle may be dysfunctional. That's why you don't see the real RVSP, that is right ventricular systolic pressure. So you can see the echo here. The left ventricular contraction is good. Right ventricular contraction is not that good. Right ventricular free wall is not good, whereas left ventricular free wall is contracting. So here you can see that this is the left atrium, this is the right atrium, and descending at here, the pulmonary veins are not entering here at all. The pulmonary veins are not seen entering the LA. The distance between the left atrium to the aorta is somewhat more here. And simultaneously, if you do the echocardiogram of ultrasound abdomen, here, this is the inferior vena cava, this is the aorta, there is a channel which is coming and entering in the liver. So this is nothing but pulmonary veins all forming a chamber channel, and which is opening into the liver. This is called as infradiaphragmatic total anomalous pulmonary venous return. So what will happen in this? All these pulmonary veins, they join behind the left atrium and form a common pulmonary vein. This common pulmonary vein travel behind the heart and below the diaphragm, and then enter the liver. So what will happen? Foramina ovale will have the admixture in the right atrium, which foramina ovale, the blood will go into the left atrium, left ventricle from their aorta. So here, most important aspect is obstruction at the diaphragmatic level or in the liver. If you take the umbilical vein, umbilical artery, or right atrial saturation, all are equal. So in this condition, the right atrial saturation equal to left atrial saturation equal to the left ventricle equal to the right ventricle equal to pulmonary artery equal to the aorta. So this kind of information you may gather if you have pulmonary umbilical vein and umbilical artery saturation together. So the take home messages are unusual PPHN disproportionate to the ABG, and when you have a disproportionate echocardiogram, when cardiologist is telling that right to left shunt across the ductus arteriosus, and if you have X-ray of that kind, please suspect infradiaphragmatic obstructive TAPVR or TAPVR with obstruction. It can be supracardiac as well. So let us look at the second case example. This is a day 3 term baby, weighs 2.5 kilogram, referred from Guntur with a diagnosis of total anomalous pulmonary venous return here. Echocardiogram showed dilated RA, tricuspid regurgitation, right ventricular pressure are 60, baby was intubated and subsequently improved and became OT dependent. So baby was shifted for the cardiac surgery in a stable condition, but septic marker positive. So what is your X-ray comment? If somebody wants to give comment, they can give. I am actually seeing this. So here you can see that the pulmonary, you can see that the cardiothoracic ratio is normal. The what is that? Situs is solitus. You can see the vascularity. Can you see the vascularity? There's absolutely no vessels are seen. Lungs are dark. This is called as oligemia of lung. Oligemia of lung fields. When you have this kind of a situation, that obviously suggests you that this is a pulmonary outflow tract obstruction. So if you take ECG, the ECG, if you give it to an adult cardiologist without telling the age group, they will tell it's a normal ECG, because here you can see there is no R wave in V1 and there are good S wave in V5 and V6. It's a totally like adult form of ECG. They will tell that it's a normal ECG for an adult. So any normal ECG of adult pattern in a neonate is 100% abnormal. That suggests that it's right ventricular problem. So here you can see that the QRS axis is somewhat normal axis and right ventricular forces are totally absent, suggestive of it may be just a hypoplastic right heart syndrome. So now when you have that, the ABG also, you can see the ABG pivot is 44. On ventilation pivot to 44, that suggests you that there is no mixing properly. There is no perfusion. So that means there is a deoxygenated blood is completely mixing into the systemic circulation, leading to low PO2, low SPO2. So the echocardiogram showed there's a RVSP of more than 60. I will cite as solitus, and there is right to left shunt across the AST. The right ventricle is hypoplastic, pulmonary valve is atretic, and there is a PDA with left right shunt. Here important aspect is PDA with left right shunt. Whenever you have high RVSP, PDA with left to right shunt, that is not PAH. So previous case, high RVSP, PDA with the right to left shunt, that is 100% PPHN or PAH due to whatever the context, and it is right to left shunt due to in PDA due to suprasystemic pulmonary hypertension. Here PDA with the left to right shunt and RVSP is more, that suggests that it may be pulmonary valve or pulmonary atresia. So in pulmonary atresia, intact septum, right ventricle is hypoplastic, pulmonary wall is hypoplastic. So it's a pure duct dependent circulation. So if you take ECG, the ECG will show of hypoplastic, the right ventricular forces are less and there are good left ventricular forces. And X-ray will show ischemic lung fields. So here you can see the angiogram which is done. The angiogram is showing that the pulmonary wall is atretic. Here you can see the pulmonary wall is atretic. We have taken a wire to perforate this atretic pulmonary wall. Another catheter is coming from the ductus arteriosus in the pulmonary artery here. So you can see that that is the, sorry for that. So this is the wire, a chronic total occlusion wire or CTO wire. We push the wire and we perforate the pulmonary wall. The pulmonary wall is perforated, now you can see. So what we are doing is, we take a snare here and catch that wire in the pulmonary artery. Catch that wire and then pull that wire into the aorta and then to the descending aorta. Then after pulling, you take a balloon over that, initially a small balloon, and you inflate gradually and open the pulmonary wall. Then subsequently take a bigger balloon appropriate to that pulmonary wall annulus, and then you can see that completely the valve is opened here. You can see that that's a beautiful opening. So this is a very, very interesting treatment for these conditions, provided we should recognize this condition. So important message, any neonate presenting with cyanosis, no respiratory distress, a simple transposition of great vessels. If there is, so no respiratory distress, a simple transposition of great vessel or pulmonary atresia with adequate pulmonary blood flow. A respiratory distress with cyanosis suggestive of closing PDA in a duct dependent circulation, or cyanosis with respiratory distress, any kind of heart failure producing condition like Epstein's anomaly, tetralogy fallow with absent pulmonary valve syndrome should be considered, or sometimes associated ventricular dysfunction we should consider. So in case of oligemic lung fields, if you divide X-ray into lateral 1/3, medial 1/3, and medial 1/3, normally the vascularity is seen into the middle 1/3. If you don't have vascularity in the lateral 1/3, middle 1/3, that is called as oligemia and seen in case of atresia of the pulmonary wall. If you have vascularity in the lateral 1/3, that suggests that it is a plethora. Any increased pulmonary blood flow conditions can produce this kind of plethora. So a neonate with cyanosis, X-ray showing oligemia, please have a diagnosis of pulmonary atresia or severe form of tetralogy fallow. If ECG is showing right axis deviation with RV forces, then it is VST with pulmonary atresia. If ECG is showing left axis deviation with LV forces, you please consider it is pulmonary atresia, intact ventricular septum, tricuspid atresia, or a single ventricle with PS. Let us look at the case 3. This is the second week late preterm, birth weight 2.4 kilogram, presented with a shock, discharged from the perinatology unit. History of previous sibling death, fetal echo, no structural heart disease, mild right ventricular dilatation, right heart dilatation. There was a faint continuous murmur, and closing ductus. So one thing I want to tell you, never believe a closing ductus arteriosus. On presentation, respiratory distress for 18 hours, refusal of feeds, reduced urine output, poor perfusion, mottled appearance, CFT increase, grunting respiration. There was active precardium, gallop, and abdomen showed hepatomegaly. And look at the blood gas here, very, very disturbing. pH is 6.9, and you can see that pivot is good, base -16. All this suggestive of there is something systemic outflow obstruction. You can see the X-ray is a big heart here. There is a pulmonary edema here. You can see that. So this is the pulse oximeter, both upper limb and lower limb. What is the diagnosis? What is the diagnosis here? This is the upper limb. This is the lower limb here. You can see that blunting of signal in the lower limb. So this suggests that there is a brachiofemoral difference suggestive of it's a coarctation of aorta or systemic obstruction. Now you look at the echocardiogram. Ventricular dysfunction is there. Heart is dilated. So now you see the aortic arch. There's a severe degree of coarctation here, significant coarctation, and there is a gradient. So typical presentation of the baby with mottled appearance, and reduced urine output, hepatomegaly, acidosis, suggestive of it is a neonatal coarctation. It's very important to recognize, otherwise baby will die. So baby was started on prostaglandin, dobutamine for the ventricular function, and now you can see the waveform, how it nicely became waveform, and that's the time to send for surgery. Sometimes while baby is in acidosis, cardiac arrest, if you do surgery, generally they don't do very well. They will have hyperkalemia, they all die. So hypotension, hypoperfusion, cardiomegaly, delayed CFT, poor perfusion, mottled limbs, reduced urine output, acidosis, grunting, that is due to again a physiological means of P due to pulmonary edema suggestive of it is shock presentation. Any symptoms during the closure of the ductus, refractory shock, weak pulse, and disparity in plethysmography between upper and lower limbs, please suspect coarctation of heart. So this is the neonate which is presenting. What is our diagnosis? You can see clearly here. So it is inspiratory stridor. So any inspiratory stridor usually suggests of upper airway obstruction. Any expiratory wheeze, we can call it as, that may be due to any kind of lower respiratory tract infection or asthmatic kind of situation. Here upper airway, this is classical of upper airway obstruction. Baby went to some center, then they said baby is not well, antibiotics were given, and then referred to one of our center. Then we found upper airway obstruction. Then baby needed ventilation. Then you can see here. So that is the trachea. You can see the tracheal tube which is getting compressed. So now you can see one aortic arch, another aortic arch. So you can see beautifully that is the two aortic arches. So this is the double aortic arch. Very, very important to diagnosis. This is treatment is very simple. You don't even do midline sternotomy. You go thoracotomy and you cut one and then ligate on either side. We have series of cases of double aortic arch and right aortic arch diagnosed and underwent treatment because of education, and we all work together in Hyderabad with various NICU units, PICU units. That's why the diagnostic yield is very high, at least in Telangana. I am sorry, I don't know the people who are all attending this session, but I feel that it's important to have education among ourselves to know these kind of cases. Upper airway obstructions are due to double aortic arch, circumflex arch, and pulmonary artery sling. This is the pulmonary artery sling. One of my technician, late Rizwan, he was wonderful in diagnosing pulmonary artery slings. He diagnosed 3 cases. All 3 cases improved very well in remote areas. So just telling you examples. This is another 20 days of full-term baby, non-consanguineous, and presenting with 4 episodes of a generalized seizure activity, history of sibling death, and other parameters are normal. Calcium is normal. This is the ECG. Anybody would like to comment? The baby was referred for echocardiogram, but we did a ECG in this particular baby. So there were 2 sibling deaths. You can see carefully if you look at ECG here. This is P wave and QRS, then T. You can see the QRS T, it's very wide. There's a QTC interval is increased. How to diagnose that? By visually without calculating that. This is RR interval. Your QTC interval should be lesser than half of the RR interval. Here in this particular case, you can see more than half of the RR interval, suggestive of it's a long QTC. So you can calculate long QTC by applying the formula is called as Bejet's formula. In that, QTC is equal to QT by square root of RR interval. So if you have more than 460 milliseconds, that is a long QTC syndrome. Several incidents, I can't tell you examples, that we routinely miss long QTC syndrome in all our ICUs. So whenever you have rhythm abnormality, any suspicion, sibling death, please take QT ECG and calculate QTC interval. It is not unusual. It is quite fairly easily recognizable condition according to me, and treatable condition. This is a neonate day 3 referred to NICU for management of hyperbilirubinemia with mild birth asphyxia, seizures, baby developed respiratory distress and high heart rate. You can see this. What is your modality of treatment? This is the narrow QRS tachycardia, heart rate is 280, baby presented with somewhat weak pulse, feeding difficulties, respiratory distress. So our first treatment is we will give adenosine. Most of the times, believe me, we all give underdose of adenosine. The dose of adenosine is 0.05 to 0.2 milligram. So we give 50 micrograms, and we'll just, believe me, nothing will happen. If you give 200 micrograms, nothing will happen. Second problem is your 3-way is contaminated with blood. As soon as you give adenosine, it touches the blood. In 8 seconds, the degradation will be over. That's why as soon as you give adenosine, another syringe with 3-way, you have to flush it rapidly. Then only adenosine will act. Otherwise, adenosine will never act. This is the commonest problem I have seen several units, that even though you give good dose of adenosine, it doesn't work because your nurse and fellow is not giving properly. Believe me. So if you rule out that, you give adenosine. While giving adenosine, please take ECG. This is a fundamental most. If you don't have ECG, somebody can record with your mobile video of a monitor. So this particular patient, we recorded ECG. Now you can see this is the QRS, this is the QRS, this is the QRS. In between, you have sawtooth appearance. That means this is not a narrow QRS tachycardia due to AVNRT, that is atrioventricular nodal tachycardia or atrioventricular re-entry tachycardia. This is due to atrial flutter. Atrial flutters will not improve with adenosine. They need either you can give synchronized cardioversion, electrical shock, or you have to give sotalol and digoxin combination. So this baby improved with electrical shock. Electrical shock we give very less, 0.5 joules per kilogram. That means a 3 kilogram baby you need only 2 joules. Nothing will happen. Lot of people they are afraid we are going to give the shock to the baby, move around, clear. All these instructions are there, but nothing will happen. You just give 3 joules, it will be converted immediately. It's a most underutilized modality of treatment according to me is electrical DC shock. Please give that one, invest on that, whoever is maintaining NICU and PICU. So this baby improved very well after that. A 12 years girl presented with awareness of heartbeat, palpable cardiac pulsations, normal heart sounds, no murmur, ECG is normal. This is the chest X-ray. Now chest X-ray you can see that only finding is little bit bump here. When I palpated my uh, thumb, the thenar eminence was pulsatile like this, lifting. So you can see that this is what it is, echocardiogram. Echocardiogram, interesting. You can see echocardiogram. The findings are a big sac seen here. There's another sac at the right ventricular apex, cystic like structure. You can see that cystic like structure here. So again you can see cystic like structure here. Interesting, you can see cystic like structure. Some you can see some particles are seen. So what is our diagnosis? What is our diagnosis? So we don't have real diagnosis, right? So it may be cyst, it may be double chambered right ventricle, it may be congenital diverticulum, traumatic pseudoaneurysm, or acquired cyst. So we did MRI. MRI is showing only cyst and cavity. Then you can see we opened that. This is nothing but hydatid cyst of the heart. So the cyst is projecting, protruding outside. You can see that very nicely. And then we have to expel that. When you are removing this cyst, first treat with albendazole for 3 weeks. Then you aspirate, cover entire thing with a hypertonic saline and formaldehyde. Hypertonic saline. Otherwise, what will happen? The toxins will go and produce systemic shock. So then you have to remove completely. Enucleation should be done. That's what it should be done in this case. It was done. We all know that echinosis, there is a definitive host called dog, intermediate host called goat or sheep, and scolex will be formed, and inside that there will be daughter cyst. What I was showing you here is nothing but daughter shape. This is the daughter cyst here which is seen. So these kind of cases you rarely see. I just want to show you out of interest so that everybody can see. Nowadays we are seeing lot of COVID. We had last seminar variety of COVID cases presenting with aneurysmal, non-aneurysmal, and fever, rash, high D dimers, IL-6, all that we are managing. But look at the classical case. In this context, everybody has forgotten classical case. A 33 months baby with a high grade fever, rashes one day, one episode of vomiting, and we had maculopapular rash. You can see here congenital injection is there, lips are red. So what do you do? Would you like to ask for the echo and go for the G scores, and you want to have the cardiologist opinion that coronaries are dilated, then only I will give gamma globulin? Now this is the lab parameters. The WBC has a tendency to rise and then settle down. and progressively there is anemia, and platelet counts you can see very high, 9 lakhs here. CRP which started increasing and fluctuating here, ESR which is steadily going up. So what information we require? According to me, Kawasaki disease is a clinical diagnosis. It is not an echo diagnosis. Please believe me. A clinician should carefully look into that, correlate with your investigations, then you should come to an understanding. If you have doubt, the thing is you should ask your immediate colleague. It can be junior or senior or your colleague. Ask to give independent opinion whether it is matching that. So this is a classical case of Kawasaki disease, where fever more than 5 days, rashes and maculopapular rash, congenital injection, and lips and tongue you can see that, which is strawberry or cracked lips, and labs showed that there is raised in CRP, ESR, and platelet count. This is the point where you have to give gamma globulin. If you don't give gamma globulin, it is going to produce aneurysms. Believe me, in this case, we went by only clinical grounds. The echo is normal. You can see the coronary arteries are normal. Just a mild dilatation and little bit reduced tapering. Otherwise, it's absolutely normal. If you don't treat this condition, potential danger of developing coronary aneurysms. Once you give IVIG, the first thing what we see is reduced irritability. Irritability will come down. Second, fever will come down. Third, CRP will come down, and ESR will take at least 1 week, at least 1 week to come down to normal state. So, and other laboratory parameters like urine routine and SGOT levels, albumin globulin ratio will be reduced. All this suggestive of it's a Kawasaki disease. So my message to all of us: G scores are important, but may not be important for the diagnosis. It is important for the prognostication. It is important for the treatment response. When you have G scores plus 10, prognosis is poor. When you have G scores are higher, it supports your diagnosis, but it is not the diagnostic parameter. Believe me that. So this may be improved very well. Gamma globulin given, aspirin was given, subsided, and subsequently 3 to 5 milligram per kg given for next 4 to 6 hours, 6 weeks. This is another 4 years old boy, fever, abdominal pain, pedal edema, developed upper limb weakness, and gallop. Now you can see that when you have a gallop, it's very important. It has to be cardiomyopathy. Myocarditis due to viral infection, especially during COVID era. Not necessarily they should have history of a COVID. You check the antibody titers. Antibodies will go more than 100. So this is a non-COVID patient, developed a gallop and present to us with really hypotension and features suggestive of a heart failure. When we did echocardiogram, a gross ventricular dysfunction, and you can see the intraventricular thrombus, an early thrombus. That's why it is actually mobile. Central translucency is there. These are the patients, they develop a stroke significant to CVA, and they may die also. So that is important. It's important to note this patient was treated with inotropes, diuretics, anticoagulants, and other supportive management. You please see this. Now thrombus totally disappeared, ventricular function totally improved. So please don't go with the an impression that all myocarditis prognosis is poor and they develop a dilated cardiomyopathy. It is totally wrong. With available medications, we aggressively give vasodilator therapy like milrinone, dobutamine, and levosimendan. I'm not telling it's a wonderful drug and you should give, but if you give supportive medications, including levosimendan, then the improvement is very, very good. This patient received all kind of treatment, including levosimendan, and improved very well. This is a 4-month infant presented with, I may stop after 1 or 2 cases. 4-month infant presented with severe respiratory distress, gallop, cardiomegaly. You can see the heart. This patient came from Bijapur, Karnataka. So the findings are ECG. Now you can see Q waves in L1 and AVL and V5 and V6. Whenever you have ECG Q waves like this in the presence of gallop in an infant, please rule out Al Kappa. Al Kappa is a condition called anomalous origin of left coronary artery. Here you can see that this is the pulmonary artery, this is aorta. The left coronary artery is arising from the pulmonary artery, and then actually there is a steel. Right coronary artery is the only one which is supplying to the heart. That's where left ventricular dysfunction is very serious here. So because of this, baby has gross heart failure, cardiomegaly, and gallop. So we have to treat with surgically. We reimplanted that, and the baby improved tremendously well. Take home point: any LV dysfunction in an infant with Al Kappa, diagnosed as Al Kappa, and ECG is going to be very, very good clinical hallmark. Another examples, couple of examples, I may stop after 1 or 2 cases. 3 years old child admitted with severe respiratory distress, blood pressure 80. You can see the pulmonary edema here. Pulmonary edema presented with shock, S3 gallop, pulmonary edema, and there is LV dysfunction. It's not that severe, but LV dysfunction is quite significant. So what we have done, we have intubated and treated the baby, and creatinine every parameters are checked, treated with dobutamine milrinone, and we started looking at, after 2 days the BP started rising up, 130 by 82 BP, very high. Then we ourselves evaluated the renal Doppler, which showed that significant renal artery stenosis. Here you can see that renal artery is quite stenosed here. So this particular patient underwent renal artery stenting and improved very well. So checking hypertension in a critical shock stage may not give information. You have to wait for the patient to improve, and constant trends are important to check the hypertension stage is there or not. Similarly, we diagnosed several cases of, at least 3 cases of new pheochromocytoma in our city. So post-procedure echo is phenomenally great, and child improved very well. So one more example of 27 months baby with high volume pulse, continuous murmur, and you can see that ECG here, X-ray showing big heart here, and this is actually came from Nanded. One of the pediatrician he sent. You can see the CT scan. The right coronary artery is very much dilated here, and which is causing, you can see the right coronary artery to fistula. There's a very much enlarged here. This is a coronary cameral fistula. He was having intermittent chest pain. So when you have this kind of a fistula, it is mandatory to close them. Otherwise, they develop a myocardial infarction, exercise chest pain, exercise dyspnea, over the period of time, ventricular dysfunction. What we do is we take them to cath lab. We form the arteriovenous looping. We go catheter, cross that vessel, and then snare the wire into IVC. You have a circuit from femoral vein, inferior vena cava, right atrium, fistula, aorta, and then formed that. Then we put a device. You can see we positioned a device, and 2 devices we positioned in this case, and child did extremely well. So just to showing you some of the interventions, how we can manage that. Now you can see both right coronary artery, left coronary artery, both are filling, and the child is doing well. Complete procedure, occlusion of the fistula happened. So these are all echo. The last case, probably I'll give this case. This is a 25 days mechanoaspiration baby with a big heart. This is the moderate VST, moderate to large VST. Such a big heart mechanoaspiration. One of the neonatologists in our city, Dr. Murki, was treating. There was a failed extubation, absolutely failed extubation. We managed all medications given, diuretics, inotropic support, vasodilator, but no way that there was improvement. So this is the condition where we thought we'll draw a line out of the way and go and do the procedure. So what we have done in this particular case, we crossed the ventricular septal defect. Here you can see that, and we put an umbrella called Konar MF umbrella. This device actually developed by me in association with LifeTech company, and we could completely successfully close that fistula, that ventricular septal defect. You can see the device is well positioned, and baby could be extubated and discharged. So fantastic improvement is there. So I will probably wind up this. To summarize, heart disease in children are quite challenging. Meticulous evaluation, including history and other available investigations, provide proper diagnosis. It's important to have the good diagnosis for an appropriate treatment, and treatment is always individually based and custom made. We cannot tell that VST should be closed after 3 months of age, after cardiac failure. In this case, you saw that. Similarly, in case of Al Kappa, in case of Kawasaki disease, in case of neonatal heart diseases. So thank you very much for your patient listening, and I really would like to have feedback and questions. Next time we are coming to you with a different set of cases. Some of these cases are repeated, and repetition thinking that people are from different states, different institutions, and unfortunately I did not get the names of the people. Otherwise I will be very happy to have the interactive session. I will closely work with the IT people to have the interactive session next time. Thank you very much. If you have questions, we can have still some interaction. So I am really sorry for that. Probably we'll work on that. I would like to take these questions and respond to you, because I am not seeing any questions here. If there are questions, I can answer now. Can you show me at least one question? Can you read
Yes, sir. Just a minute.
or share that immediately? Still, lot of people are attending, listening to me. I appreciate that.
LV dysfunction in newborn is one question from Dr. Naveen.
Dr. Naveen, thank you very much for that question. LV dysfunction in newborn uh, is a very, very important question. Any newborn presenting with ventricular dysfunction, please remember it is volume overload, pressure volume overload situation. So there is acute ventricular arterial decoupling. Left ventricle is actually not under stress during fetal life. The ventricle which is going under stress immediately after fetal life is the left ventricle. If there is aortic obstruction, interruption, or coarctation, then you will have left ventricular dysfunction. Biventricular dysfunction, both the ventricular dysfunction due to volume overload situation or any kind of arrhythmias are possible. So any left ventricular dysfunction, we should suspect a systemic outflow obstruction. So more questions?
Any cause apart from Al Kappa?
So in an infant, not in a neonate, infant, if you have ventricular dysfunction, number one, tachycardia, cardiomyopathy, Al Kappa, calcium deficiency, this is very important, and also thyroid problem. We have two cases with the thyroid problem recently, and viral myocarditis and carnitine deficiency. These are the causes during infancy. They can have ventricular dysfunction apart from systemic outflow tract obstruction. So oligemic lung fields we discussed. Pulmonary atresia, what are not able to see films or reports. We are not able to see films or reports. Okay. Coarctation, compression by aortic arch. We saw that right aortic arch, probably you are answering that. Adenosine. Adenosine, please give liberal dose. And if you don't give liberal dose, that is going to be a serious issue. I request all of you give adenosine, nothing will happen. In 80 seconds, adenosine will be degraded. So even if you give little bit of high dose, there will be transient bradycardia, transient even asystole also, but immediately it will come down. If you have that fear of asystole, give external message or keep adrenaline ready or atropine ready. If you have that problem, immediately you give. So why do, I'm reading question, why do cyanotic heart disease is seen mostly in term babies, not in preterm? Wonderful question. What will happen? Cyanotic heart diseases in upper limb in infancy, in fetal life, good oxygenation blood will be there. In case of a TGA, for an example, the diseases which produce critical heart diseases, they tend to terminate naturally, automatic. Natural abortion is common in serious heart diseases. The heart diseases which are surviving will have fetal circulation much better than the postnatal circulation. For an example, TGA, fetal circulation is very good. Malposed great vessel, like a single ventricle with malposed great vessel, DTJ with malposed great vessel, whatever you take, all fetal circulations are favorable. That's why they tend to go till term. It's a wonderful question. Somebody asked, I would like to see the person. Mahipal asked this question. I really appreciate you for this question. Fetal circulation is favorable. That's why they they are born with term babies. The serious heart diseases like a heterotoxic syndromes or genetic anomalies, they are the ones which preterm babies they tend to terminate naturally. Please tell us how to differentiate between ARF and infective endocarditis by echo. Srilata, that's a very good question. Acute rheumatic fever, you will have significant mitral valve abnormalities. The PML will be fixed, it will not move. AML will be mobile. There will be rupture of caudal teninae or AML prolapse and thickened mitral valves, rolled out mitral valves will be there. There will be mitral stenosis, which is the central. Mitral regurgitation also will be central. Whereas in case of endocarditis, you will definitely see the vegetations on the mitral valve, and there is a peri inflammation you will see in the form of pericardial effusion, hyperechogenicity, which is more common in case of endocarditis. Vegetations and complications, eccentric mitral regurgitation, and already a developed rheumatic heart disease is seen in case of mitral stenosis. LV dysfunction in neonate, any cause apart from alpha. What the management of myocarditis with LV dysfunctions are? Management of myocarditis utter Dr. Rahman. So management of myocarditis with LV dysfunction, first line treatment is intravenous diuretic therapy. Second line is inotropic support and vasodilator. And third line where we are going to start is beta blocker. So as soon as baby comes, you give aggressive diuretics, check the inferior vena cava, and if it is too much of collapsible, then you have to balance it. Because when you give diuretics too much and start inotropes, there will be non-responsiveness to the inotropes in the presence of hypovolemia. Please remember that they should have good volume to have the response from the inotropic support. So first line treatment diuretics, then milrinone, that is vasodilator plus inotropic. Then third line medication is you are going to give beta blocker treatment. Of course, levosimendan is case based basis. Sometimes when patient comes very shock state, low BP, please don't start levosimendan. A stable, reasonable stable cases, Heart rate is somewhat settled cases, you start levosimendan. In large AST, what is the earliest age to operate for recurrent LRTA? Believe me, ASTs generally they don't produce heart failure, they don't produce lower respiratory infections. If AST is producing heart failure, lower respiratory infections, first rule out associated problems like post-Nageshwara shunt, VST and PDA. Now, AST with non-compliant right ventricle. The right ventricle is like a balloon, it distance. In case of a stiff right ventricle, where they have heart failure, and posterior AST, not centrally located AST, a posterior AST, all pulmonary venous flow will come to the right atrium and then right ventricle. These are the cases will have heart failure and respiratory tract infection. These babies we should operate even at 1 year of age. We have so many cases, we operate even at 1 year of age, these kind of cases. So I think we'll wind up the session. If you have any questions, you please still put in the chat box or email or WhatsApp me. I'm very happy to take your questions. Thank you. Good night and have a great weekend. Happy Dasara to all of you and really appreciate you for attending my lecture. Thank you very much. Take care. I'm closing this session.